we'll move swiftly on to our next speaker of the day. We have Dr. Nick Brown speaking for us, and he'll be giving a talk on has there been progress in the development and use of diagnostic tests to combat AMR? So Nick has been a consultant medical microbiologist at Adam Brooks Hospital and associate lecturer at Cambridge University since 1996. He is employed by the Public Health England, so PHE, and is the Clinical Services Director of PHE Cambridge Laboratory and Interim Clinical Services Director of PHE Cambridge Laboratory and Interim Clinical Lead for PHE National Infection Service Regional Microbiology Laboratories in England. Bit of a mouthful. Nick has a career-long interest in the use of antibiotics and antibiotic resistance, and he was president of the British Society of Antimicrobial Chemotherapy, British Society for Antimicrobial Chemotherapy, BSAC, from 2012 to 2015, and is currently the BSAC Director of Public and Professional Engagement. So without further ado, Nick, I'll pass on to you. The stage is all yours. Thank you. Yes, yeah, to the side, yes. I think it's side this one. Maybe.
Great. So thank you for that introduction. Thank you for the invitation to talk here today. As has already been said, I have been involved with BSAC for a number of years now. And some of the words that Dame Sally mentioned in her talk in terms of advocacy, in terms of the credibility of those that are talking, informing, influencing are certainly part of my day-to-day life. At BSAC, if you haven't looked, by all means, look on our website, join it. It's free to join, and there are an enormous number of resources that will be very helpful to you. And we hold a number of national and international meetings, which again, you can join if you're a member. We are also very active politically. We provide the secretariat to the all-party parliamentary group on antibiotics, and in the last few weeks have been involved in a select committee style inquiry into water, sanitation, hygiene in healthcare facilities in developing countries. And we've also recently supported the funding and appointment of 2 interns to work in the House of Lords on issues relating to AMR. So the first 2 interns started work with Baroness Bennett of Manor Castle. So that's Natalie Bennett, who used to be the leader of the Green Party in the beginning of September. And they will work for between 6 and 12 months, 1 day a week on release from their PhD programs. I think that's an initiative which has huge potential to get people more involved in the politics and work of in the AMR field. So I was asked to talk about diagnostic tests. Dame Sally mentioned it very briefly. And I usually start by showing this slide with LP Garrett, who within the BSAC, we see as the grandfather of work on antibiotics, particularly on the use of antibiotics and laboratory testing of antibiotics. And he worked from the 1950s through to the late 1970s here in London and wrote many of the early papers on laboratory testing of antibiotics. However, for me, one of the key aspects of this whole talk is really to emphasize that it's not the laboratory test that's most important, it's how you use it. And that, I think, is the single theme that I will take through this talk. Here, it's amazing, these pictures were only taken 4 years after the previous one of Garrett in 1982, but I'm sort of sitting here looking at you, I realized that almost everybody in this room was not even born in 1982. Bananarama on the right were the pin-up girls of university life when I was at university. This song was number 4 in the charts in 1982. There you go. I guess most people in the room are aware of the O'Neill Review, commissioned by David Cameron when he was Prime Minister. Jim O'Neill was an economist working at Goldman Sachs, chosen deliberately because he was not a scientist working on antibiotics. And he was asked to look at antimicrobial resistance and produce a report, which was published between 2014 and 2016. And these are the two key findings that are spoken about in almost every talk on AMR. On the left, the potential cost to the world economy of antimicrobial resistance, if unchecked, by 2050, $100 trillion per year. And that's equivalent to roughly the gross domestic product of the whole world. $100 trillion. So, I mean, it's, I think, a trillion, 10 to the power of 12. You have to think how many noughts that is. It's an awful lot of money. And then in terms of impact, 10 million deaths a year by 2050, so that it would outstrip cancer and many other important causes of death. And Dame Sally has already mentioned the Graham report, which was published in February of this year, which has already demonstrated that we're well on the way towards approaching that figure. But many people have not appreciated that Jim O'Neill's report also talked at some great length on the use of diagnostic tests. And in 2013, I was asked to talk at the Parliamentary Science and Technology Committee about use of antibiotics in hospitals. And this was just after Dame Sally's Chief Medical Officer annual report on AMR was published in 2013. And one of the points that I made that really resonated with parliamentarians was that at the point that a doctor is prescribing an antibiotic, they do not know what the cause of the infection is, or indeed often whether the patient has an infection or not. And they were sort of dumbstruck by that you know, an antibiotic prescription is almost always a best guess prescription, and you do not find out what the cause of the infection is, what the antibiotic susceptibility of the organism is, or indeed whether the patient has an infection at all, until at least some hours later, and often some days later. And so this was picked up in the O'Neill Review, and the document here was specifically dedicated to diagnostics. And the situation that I describe is on the left of the diagram here, that often a doctor will prescribe what is essentially an empiric antibiotic, and that often, if they get it wrong, the patient fails treatment, and therefore you need a second empiric antibiotic, or perhaps a third, and often optimal treatment may never be reached. If you have a diagnostic test, and often diagnostic tests are not done, particularly in the community, in GP practices, you're treated blind, so to speak, then you may find out sometime later what the cause of the infection is, and you may be able to direct antibiotic therapy, but that is often a protracted process. And so what Jim O'Neill proposed was that there should be a new initiative to try to improve diagnostics and ideally have rapid diagnostics. And his challenge was that by 2020, every antibiotic prescription should become an informed prescription. That is, you should know at the point of writing the prescription what the cause of the infection is. Now, talking to him subsequently, he said, well, he didn't just made that up. He didn't really expect 2020 to be the year that this was achieved, but he really just wanted to stimulate debate and action to improve the use of diagnostics. And indeed, if we look now at the current UK 20-year strategy, if you like, for antimicrobial resistance, there are three key bullet points within that, and new diagnostics is one of those. So I think this is often the neglected element of the whole AMR action plan. At the same time, a prize fund was launched, similar to the fund that Dame Sally's already talked about in other settings, the Longitude Prize. This was for up to £10 million to reward a company that developed a completely innovative new rapid diagnostic test. And that the applications for that have now closed and they're being assessed. Originally, for those who haven't come across it before, the Longitude Prize was developed following the passing of a Longitude Act in 1714, which was in Queen Anne's time, which was in response to public concern about the number of ships that were being lost at sea because sailors couldn't navigate well. Although latitude is quite easy to determine because you can look at the stars or measure angles to the sun and so on, longitude is much more difficult because of the rotation of the Earth. And so the Longitude Prize was launched with, in those days, I think it was something like £10,000 as a prize for someone who could come up with something to solve this problem. And the winner at that time was a man called John Harrison, whose innovative solution was a clock. And he built such an accurate clock that could be used at sea that sailors could compare where they were with on the clock with the time at a known port of known longitude. And so then they were able to work out where they were. So we have something similar now for antimicrobial resistance and diagnostic tests. So one of the big problems that we have in lab diagnosis of infection is that we are still in 2022 working primarily with technology from the late 19th century. For those of you doing practicals in Tennis Court Road, you'll know that we still use Petri dishes, we still culture bacteria. And fundamentally, the problem with that is that it relies on at least one overnight incubation and often multiples of overnight incubation to get a final result. And also the layout of the lab. So this is a photo I took on the right-hand side here of Fleming's laboratory in St Mary's Hospital in Praed Street in Paddington, which is now a museum, which you can go and see if you want to. And on the left, the clinical microbiology laboratory at Addenbrooke's Hospital, this picture taken in 1987. We'll come back to that in a bit, but essentially these are the same, apart from the fact that, I haven't got a pointer, I don't think, but behind Fleming's microscope, you can see his packet of fags sitting in a glass Petri dish, which you wouldn't have today. If we're looking at the development of these new diagnostic tests, O'Neill also suggested that a variety of different things could be looked at in order of complexity. So low-hanging fruit first, is the infection bacterial or viral? Well, does the patient have an infection at all? And if it's viral, then clearly almost always the patient will not need an antibacterial agent, an antibiotic. What is it caused by? Does it contain antibiotic resistance determinants? And that is perhaps more important than the final, can we confirm susceptibility? So we need to detect resistance before confirming susceptibility as an essential need. And the response has been remarkable. I'm not going to go through any of these, and as I've caveated at the top, other systems are available, but there is now a plethora of automation, small automation, rapid testing with a variety of different technologies, either based on PCR or molecular genomics, most commonly nowadays, to detect a lot of different infections and rule out a lot of infections, which is sometimes is equally important. And I would guess if I had to summarize some of the issues with this, one of the main problems has been going from development into clinical utility. And again, this is a point I'll come back to you later, but often these tests are quite expensive. Producing the business case to demonstrate that they should be taken up into a healthcare setting which is very strapped for cash, it has been difficult. And in part, that is because the evidence to support their use has not been terribly convincing as yet. We know that they do what they say on the tin, but demonstrating that they actually make a difference to patients is, I think, the key sort of holy grail, if you like, which we need to determine before we can start using them. But this is just one example. The reason I show this is that this was a slide that I made the week before lockdown at the beginning of the pandemic. So this is what we were going to before SARS-CoV-2 hit us. And just one example from the New York Times, new genomic tests, and there are lots of examples of very similar initiatives that will help identify the causative organism and at the same time the presence or absence of resistance determinants, and to give you a quick test within hours. And that was just as Dame Sally described. That is part of the current UK AMR action plan. And this is just a diagram taken from the group that are charged with implementation of that plan with regard to diagnostic tests. So new innovation, new technology, this is the left-hand side of the slide. However, I think we now appreciate that there is probably not going to be a golden bullet. I think O'Neill, the vision initially was that someone would invent a black box which would be completely new, revolutionize infection, and would give you a result at the, in the doctor's consulting room instantly before the prescription was written. That is not going to happen in the short term for everything. So a big part of the current AMR action plan is making sure that we make best use of the diagnostic tests that we've got already. And that's the right-hand side of the slide. And that is what I want to spend most of the rest of the time in this talk on now. And part of that is a concept that some people are now calling diagnostic stewardship. Antimicrobial stewardship, or AMS, has been around for many years and is all about optimizing the use of antimicrobial agents in terms of, as summarized here in the bullet points, the right interpretation of the clinical and laboratory data that we have to guide the choice of the right drug, the right dose for the right duration. So best use of an antimicrobial agent. But actually, laboratory tests are very similar, that you need to do the right test in the right situation, in the right patient, at the right time, and then interpret it correctly. And that is not as easy as you might think. So is the test appropriate for the clinical setting? Will it actually make a difference to the patient? And as I've been sort of suggesting, will it actually be available in a time scale that we can actually do something about it to affect patient care? Also, very important is misuse of a diagnostic test. Something that I've been very aware of in my own clinical practice, and something we're trying to really focus on here in Cambridge, is that there's not only over-testing, as suggested in this slide, which means that you, because of false positive results, diagnose things that the patient hasn't got, to over-interpretation of results, meaning that patients get treatment that they don't need, and all the adverse consequences of that, not least that you delay the diagnosis of what they really have got. So you can't start that treatment. And ultimately, the big problem that we have is that most use of antibiotics in humans is to treat an infection they haven't got. And that is something that we've got to fix. Misinterpretation or misuse of diagnostic tests is a key element in that. Within the laboratory, some of these concepts have been around for decades, and any trainee in medical microbiology or any of the other pathology disciplines, such as hematology, biochemistry, or so on, are always brought up to look at laboratory diagnostic tests in three specific areas. The laboratory test itself is what's called the analytical phase, and some people just focus on that alone without considering that actually what you do before that, the pre-analytical stage, and after that, the post-analytical phase, are at least as important, and in some cases more important. So, for example, pre-analytical phase includes the decision to take a test or not, what test you do, how, even simple things like what container do you put the sample in, how you get it to the laboratory. And then the post-analytical bits are how you interpret the result and then what happens next, how you report it to a clinician, and what happens in terms of the discussion about its significance and what implications it might have for the patient. And so what I'm going to do from now is just think about some specific examples of different aspects of this pathway that can have a huge difference to patient care. And there are reviews on that in the literature, and this is just one. I've blown up the center of this very nice table from one review, but with some very simple guidance. If we just look at one bit on the left-hand side, ordering the pre-analytical stage. Test only if the clinical presentation is consistent with the infectious etiology, only if the patient has symptoms suggestive, in this case, that they have a urinary tract infection. So simple guidance that we can give to the people who are ordering diagnostic tests to guide them in what they should be doing. And if I just look at urinary tract infections in slightly more detail, this is, I think, a really nice picture from, obviously, ancient times of someone looking at a urine sample. This is actually a very good diagnostic test. If your urine is crystal clear, it is exceedingly unlikely that you've got a urinary tract infection, with very high negative predictive values, in the very high 90%. And that is something that could be done very simply in an outpatient clinic or a hospital ward to prevent someone having a urine sample taken inappropriately. Because what happens if you do take a urine sample? Well, it's likely that you will often grow something because urine is often very easily contaminated by perineal flora. And if you grow something, then it's likely that it will be interpreted as being a positive sample, which means the patient has a urinary tract infection. And if that happens, then it is likely that you will be given an antibiotic, which you might not need because it is quite possible that you don't have a UTI at all. And one of the I think, very simple but most impactful studies that has been done recently in this area is the project that's called To Dip or Not to Dip. And I don't know whether people have come across urine dipsticks before, but if you go to an outpatient clinic, and often, certainly if you go to an antenatal clinic, and often if you go to your GP surgery, you'll be asked to produce a urine sample, and your urine will be dipsticked by one of the practice nurses. And these are sticks that detect blood, protein, leukocyte esterase as a white cell marker, and protein, and sometimes other things as well, depending how sophisticated the stick is. One of the most common clinical indications for us to be sent a urine sample in the hospital laboratory is that there is blood and protein in the patient's urine, and with no information at all about whether the person has any symptoms of urinary tract infection at all. So these are done routinely, and if they're positive, the sample is sent off. So what the project involved was an education program in a series of care homes in the Wessex area, where pharmacists went into the care home, and they had educational resource which was given to the carers to tell them when it was appropriate to use a urine dipstick and when they shouldn't, largely based on symptoms, and certainly not to take dipstick urine if the patient had a urinary catheter, as many elderly patients did. And the findings were really quite dramatic, that they showed that more than half of the residents, there was a more than 50% reduction in the proportion of residents who got an antibiotic for UTI, 2/3 reduction in the total number of antibiotic prescriptions, and more than 80% reduction in the number of residents given antibiotic prophylaxis. This is preemptive antibiotic therapy to prevent an infection. Those figures are just so stunning that you don't believe them when you first see them. Importantly, the research group also looked at potential adverse consequences of what they were doing. Because clearly you'd be worried if you're reducing antibiotic use that much, are some patients doing badly? And they looked at the number of unplanned admissions for UTI to hospital, also the most severe infection consequences, so urosepsis or pyelonephritis as a consequence of people not having antibiotics for simple UTI that became a more complicated upper urinary tract infection, and also calls to GPs. And as I've put on the slide, they showed no evidence of that. And this is just one set of the data that they demonstrated. So that this is a number of E. coli episodes of sepsis, so bacteremias, positive blood cultures due to E. coli, and the periods of their intervention are shown in the green circles. So there is definitely no increase in the number of cases of bacteremia, and if anything, it looks as if it goes down, but it was not statistically significant. So from this, no evidence of any adverse outcome as a result of their initiative. Very simple. Don't test inappropriately and come and draw conclusions from a test that implies that the patient has a UTI when they don't. This has subsequently led to national guidance in this area, that people over the age of 65 should not have a urine dipstick taken because the result is likely to be misleading. The next initiative that is being done nationally, this is actually going to be launched next week as part of World Antibiotic Awareness Week, is looking at what is called the whole blood culture pathway. Now, blood cultures are taken from patients usually in hospital for suspected sepsis. We're trying to sample the patient's blood and grow the bacteria that are there, but obviously they shouldn't be there. Blood should be sterile, and diagnose bacterial sepsis. Again, as with urinary tract infection, there is a whole pathway that the sample goes through from the initial decision to take a blood culture in the first place, through to the laboratory, the analyzer, the positive result, the communication of the result, and then impact on the patient. And there are a number of different aspects that NHS England are going to be focusing on. And the key ones are going to be how many blood cultures do you take? And particularly, what is the volume of blood that you sample? Because there's good evidence that the more blood you sample, the more likely you are to diagnose a bacteremia. And many blood culture bottles are underfilled at the moment. Some early research data suggesting that if you fill the bottles to the level at which they are meant to be filled, which is about 10 mils of blood, then you can increase the yield by between 10 and 15%. And that would have a huge impact on patient care. The next target is to improve the time that it takes to get the bottle from the patient's bedside into the laboratory and into the incubator. For many laboratories, that is too long. And particularly as we've now centralized a lot of our pathology services, peripheral district hospitals have to transport their samples to the hub laboratory. And clearly this introduces delay. And so we're going to be looking at that as well. The other thing that we're looking at is blood culture contamination. it's very easy to get skin organisms into a blood culture sample, and organisms like staph epidermidis and other coagulase negative staph, for example. And they can be clinically very misleading, because at the time that the blood culture signals positive, you are not certain that it's a contaminant, and you generally the fail-safe response would be to treat the patient as if they might have a genuine bacteremia. So this means, again, patients getting antibiotic therapy that they don't need for an infection that they haven't got. And there's a lot of training being done to improve the aseptic technique that is used to sample blood cultures and reduce contamination. And this has been remarkably successful in reducing rates to, in some cases, almost zero, which was, when we started this, contamination rates were sort of 8-9% of all samples taken. Internationally, the literature would suggest that a target of around 3% is reasonable, but we found that actually you can get it down to almost zero. And this is a ClickView real-time display that we have on the hospital intranet, where we can look at any moment what the hospital's blood culture contamination rate is. I'm not going to go into detail, and it's too small to read, but the table on the left is the contamination rate by department. And, and we can also drill down to the contamination rate by individual. We know who has taken every single culture. We know who has got the high contamination rate, and we can target them and re-educate them so that it goes down. But actually, the physician's assistants who take most of the blood cultures are very competitive. They know what their own contamination rate is, and they're devastated whenever they get a contaminant, which is very encouraging. So let's just now focus on some of the laboratory aspects. Again, some of this is not rocket science. These are laboratory turnaround times for urine cultures in the dotted line, I think, yeah, and stool cultures in the solid line, depending on what day of the week your sample is taken. And because the laboratory didn't work at weekends in the past, we worked on Saturday mornings, but not for the rest of the weekend, your turnaround time would depend on which day of the week that you'd presented to your doctor and had a sample taken. And simply by implementing 7-day working, the turnaround time is evened out. So I just put this up as a very simple way that the laboratory working practice can dramatically change the output that patients will eventually see. And there have been a number of other initiatives that have been introduced into routine laboratory work over the last 10 years. I think probably there's been more change in the last 10 years than in the last, the 20 years before that. Improving automation, particularly, a lot of changes to the way that we test for antimicrobial susceptibility, identify organisms, and so on, and obviously the increasing use of genomics. And I haven't got time to go through all of those in detail, but just quickly to bring out some points. Laboratory automation is now almost universally present certainly in big laboratories. This does not change the basic diagnostic test that is being done, which is still culture based on Petri dishes, but it does improve efficiencies of dealing with those within the lab. And this is the same laboratory that I showed before, comparing it to Fleming's, but this is now with what is in effect a sushi bar for Petri dishes that transports the plates around and will put them in, and then it has sort of valet parking for Petri dishes in the incubators at the ends, all based on barcoding and scanning. And you will see in the picture on the right-hand side, one of our laboratory technicians now reads plates on a computer screen, very high quality images, and we use that, for example, to measure zone sizes when we are testing for antimicrobial susceptibility. So the accuracy of that testing is now vastly improved. The use of mass spectrometry to identify organisms is now almost universal in larger laboratories. So rather than simple tests like Lancefield grouping of streptococci or oxidases or catalases, coagulases, and so on, today almost every organism is just put through mass spectrometry by using MALDI-TOF to identify them, and that can give you a very quick result, which you can do from a culture plate set up on the same day. So for a positive blood culture, we incubate a blood plate for about 4 hours, and that usually has enough organism on it for us to be able to put through the MALDI-TOF and get a same day identification, which certainly for contamination is very useful in ruling out a genuine bacteremia on the day that the blood culture signals positive. And sometimes we get surprises with other positives too, of course. Then technologies such as the TACMAN microarray. This is a technology which enables, you can see the sort of tree and bud sort of structure of the film array here. Each of those buds contains freeze-dried PCR reagents for a single molecular test. And this technology enables us to do 96 tests on a single sample. Each of the wells is separate, so that it's not multiplexing. They are independent PCR reactions, which means you get over some of the problems of multiplexing. And we use that during the COVID pandemic to identify secondary bacterial infection in our ventilated patients. And we continue to use it since. And this is the spectrum of organisms that we test all at once in one sample. And the process is very quick. It actually is slightly longer than it says here, but within between 2 and 3 hours, we can get a result on all of that. And we've demonstrated that, first of all, time to result is very much quicker compared to culture. So the culture is in the left-hand graph in blue, and the TACMAN microarray on the right in red was on average 58 hours quicker. So really quite dramatic. And it made a difference too. So in about half of the patients, antibiotic therapy was positively influenced, either in terms of de-escalation or stopping, and sometimes modification. So that had a huge impact on the way that we managed COVID here in Cambridge. And our mortality from patients ventilated due to COVID was amongst the lowest in the country. So we think this in part contributed to that. I'm stuck. There we go.
There you go. Yeah.
Okay, so as I come towards the end now, I think one thing that is very important to stress is the interpretation of a test and understanding of the performance characteristics of the diagnostic test that you are using. And I'm not going through a sort of statistical analysis of sensitivity and specificity, because I'm sure that everybody here is aware of that. But the point I wanted to make is that most clinicians do not understand how a test works or the characteristics of test performance. They will take a result on face value, and if you write positive or negative or isolated, not isolated, whatever, detected, not detected, they will believe you. And one of the key aspects of this that they do not understand is the importance of the pre-test probability that the patient has the condition that you are testing for. They might understand sensitivity and specificity, perhaps, if you're lucky. But they do not understand that the positive predictive value of a test, that is the likelihood that a positive result means that the person has the thing you're testing for, and is obviously influenced by the number of false positive test results that you've got. The positive predictive value falls off a cliff, essentially, as the prevalence of the disease falls in the condition, in the population that you are testing. And so even for a test with a very good specificity, where you'd expect the number of false positives to be lower, when the pre-test probability falls below about 20%, you can see that the positive predictive value goes down very, very dramatically. And a very good example of this was seen here in Cambridge in the COVID pandemic. Many of you will be aware that we had a lighthouse laboratory based on the Adam Brooks campus for testing people in the community, one of the Pillar 2 laboratories. It was high throughput. It was doing between 10 and 15,000 samples per day, testing just for SARS-CoV-2. And what I've shown here on the left-hand side are all the results from tests performed during November 2020. So this was the second wave of COVID. And the print is, unfortunately, it's quite small, but what we are looking at here are the CT values, the cycle threshold values for the PCR reactions that were obtained. And in the test that we were using, a CT value of less than 34 was interpreted as being positive. And they are shown in the pink color. However, we got a lot of results that were in the range of 34 to 36, 37, and they are shown in blue. And I was told off for suggesting that these were false positive results. They said, I was told they don't occur. You can't get them with a PCR reaction, which is obviously not true. But they represent residual RNA just hanging around, or in cases who are getting better. And we're detecting the sort of limit of detection low-level RNA. However, you can see here that we get a reasonable distribution of positive results with CT values, and then we get this secondary spike of the CT values over 34. By the way, we never isolated virus from any of those higher samples, and even if we repeated the test, they would often be negative, true negative, or nil the second time round. But the reason I show it is that the second graph on the right-hand side, July 2020, was when we were in the lull during the summer after the first wave. And you can just see the difference in terms of the number of true positives and the ones that are at the limit of detection in blue. All of these results and national surveillance were classed as being positive. So they are all counted in national statistics as being cases. But I would put to you that the ones on the right-hand side, probably about half of all the cases are wrong and have been misinterpreted because of that, just because the pre-test probability of the disease occurring in this population, at the time we were still doing mass testing of everybody, the pre-test probability was very low. So you have to take that into account when you are taking any diagnostic test. And then just finally, I just wanted to talk about reporting of the result. Laboratories play a huge part in influencing what clinicians do. And this was just one lovely example of, again, a simple intervention. This was whether the laboratory reported an antibiotic susceptibility result or not. And the two antibiotics here chosen in the study were cefalexin and coamoxiclav, two agents that are used very commonly for urinary tract infections. And this was an intervention study, and the intervention was that, pre-intervention, cefalexin was suppressed on the results, so you never told the GP whether it was sensitive or resistant. And during the intervention, that was released. And the reverse for coamoxiclav. It was released pre-intervention and then suppressed during the intervention, and the intervention period's in the grey bar, and then afterwards they reverted back to what they did before. And you can see, I think, that the use of cefalexin, which is on the left-hand scale, increased during the intervention period because you were telling the GPs what the cefalexin result was, and then when you suppressed it again, they stopped using it. So again, very simple way in which the laboratory can influence what a clinician does, an example of a post-analytical intervention. However, it doesn't always work. This is my sort of final slide. Some of you may know Andy Conway-Morris, who works, a lecturer who works in Addenbrooke's as a respiratory intensivist. His PhD was on the use of cytokines to diagnose ventilator-associated pneumonia in critical care units, specifically interleukin-1 beta and interleukin-8. And he found that they were incredibly specific for the diagnosis of ventilator-associated pneumonia, or VAP. They did a study where they looked at the impact of their test on clinical practice. And what they did was to measure these two markers in bronchoalveolar lavage fluid. And they reported, because it was so good, they reported the result with a comment as just above the graph here. If it was negative, biomarker result below cutoff, the negative predictive value is 1. And that is very unlikely. Consider discontinuation of antibiotics. And then the results of the study are shown in the graph, essentially in terms of the number of antibiotic-free days for patients on critical care unit, the study group in red, and then the routine use in blue. And essentially, there was no difference at all. So the clinicians completely ignored the result. Probably because they didn't have confidence in it or didn't understand it. Just to finalize the key messages then, I think there will be an evolution rather than revolution in the development of new tests. Initiatives to improve the use of the current tests that we've got can be very effective and often very simple. And the correct use of diagnostic tests is inextricably linked to the best use of antibiotics. Over-testing or misinterpretation of how you do tests can lead to harm. Implementation is very difficult, even with a great test, as shown at the end. And clinicians will sometimes do what the laboratory report guides them to do, but often they won't. And so on that note, I'll stop. Thank you.
Thank you, Nick, for the great talk. Does anyone have any questions very quickly for Nick? Cool. Yeah, go on, Steve.
At the very beginning of your talk, you showed those slides from the AMR report. I'm quite keen to get your opinion whether or not you think we will reach 10 million deaths per year by 2050 as a result of AMR. That obviously results in there being quite stringent surveillance and diagnostics worldwide. What's your kind of take on this?
Well, Dame Sally has already mentioned the Graham report, or what's become known as the Graham report. Looking at this was at 470 million different bits of information, collating. It was a real big data study. They estimated that, well, interestingly, they looked at both the total number of deaths in people with antimicrobial resistant organisms, but also tried to calculate the attributable deaths. That is the difference between those people who died with it or those people who died of it, because obviously the latter are probably that's the figure that we want. And the figures were quite dramatic in that those who died with it is already just under 5 million in, I think it was 2018 was the year that they looked at, which is clearly much higher than the 70,000 that O'Neill estimated to be the current death rate. And the number of attributable deaths was something like just over 1.5 million. So, you know, what was good about the study was that it almost corroborated the O'Neill findings in that the scale is similar, but if anything, the numbers suggesting we're already further along the path than O'Neill predicted. Clearly, there are issues about access to available surveillance data in many parts of the world. So there are lots of estimates and assumptions within the data, but still, in terms of being in the same ballpark, I thought it was very interesting.
I don't have any more. Just one quick one. You mentioned that there are so many new technologies that come out which can actually do point of care testing, things like that. The settings that a big problem has been the cost and outcome versus previous conferences where I was speaking to clinicians. You also, going back to the earlier report, the cumulative loss of GDP is predicted at 100 trillion, right? So have the health economics models that look into the costing of these sorts of tests and value for the NHS, for example?
I think the problem, certainly in the NHS, and quite possibly elsewhere in other health systems, is the way that you demonstrate benefit and the availability, the realization of the savings that you get. And so just as one specific example, we've just finished an evaluation of a rapid antimicrobial susceptibility testing technology that will give us the susceptibility results at the same time that we get the rapid MALDI mass spectrometry identification of an organism. So on the afternoon a blood culture signals positive, we have the organism ID and the antimicrobial susceptibility results. Now, when that is reasonably expensive and would be a significant additional cost to blood culture sampling if we implemented it. Within the NHS at the moment, clearly funding is very tight, but also importantly, staffing is very tight. 30% of posts in our lab down the road in Addenbrooke's are vacant at the moment because we cannot get anybody to come and work in the lab. So trying to implement an expensive new technology, which is an additional test, it's not replacing something that we're doing at the moment, is actually not only economically very difficult, but practically very difficult too. And of course, the justification would be that it will have a positive impact on patient care, potentially get them onto optimal therapy quicker, ultimately making them better quicker to have a reduced length of stay. But at the moment, we can't get people home because there are no care homes or anywhere else for them to go to. So again, actually realizing the potential cost benefit is difficult, that we never actually see what that benefit will be. It's just difficult to.
Right. Thank you very much for your talk. We'll give you more round of applause.